Hi there, Dr. Vincent Lamb here. Ready to field any questions you may have.
If you have any questions, please put them into chat, and the doctor will be more than happy to answer them. You want to give us a little more background on some of the things that you've been working on, Doctor?
Yeah, well, it looks like we have some chat questions, so maybe we'll go for those.
Yeah.
So I've tried, sorry, I'm just getting my bearings here. I've tried two TKIs, which worked for some time, and then chemo. Chemo did not work well for long, and I started immunotherapy, which has been working very good for 7 months. Does this mean that my cancer is no longer ALK because it's responding to nivolumab? Do I ever go back to TKIs? That's a great question. Sorry, I lost that. Just from that, from those details, it's hard to know for sure. But I would say, in general, you don't lose sort of the ALK property or characteristic of your ALK positive lung cancer. When it's progressing like this, it suggests that the cancer is progressing because it's progressing through this, more of a bypass mechanism. So it's not dependent on ALK. Sorry, we lost our place. Oh, there it is. It's not dependent on ALK anymore to grow, but it still has the ALK fusion protein, if that makes sense. So therefore, it's still considered an ALK lung cancer, but it doesn't need ALK to grow anymore. So that's why the TKIs that block ALK signaling don't work anymore. But it's growing through other mechanisms, but it still retains sort of the ALK sort of phenotype, so to speak. So do you ever go back to TKIs? That's an interesting question because, and that's not one that we have a lot of data to go off of, because as you know, we generally don't combine ALK TKIs with immunotherapy, although a lot of that data is with crizotinib. There's some data, with alectinib and lorlatinib, but a lot of the toxicity that we saw was with crizotinib and some with ceritinib. So in general, probably wouldn't go back to the TKIs, but I think this is an ongoing area that we're still learning about. One thing that that going back to the TKI would help would be to help protect the brain. And so that's why it's still an open question for me, that I wouldn't really close the door on going back to a TKI, and just watching very carefully for side effects because of the combination with the immunotherapy. Let me know if that was a helpful response. If not, please feel free to add a further question in the chat. Next question is, this might be a question for pharmaceutical. Should I be concerned that there is currently a shortage of ensartinib? I'm on a study and am at 6 years. Oh, great. Congratulations. I must say, I'm not the right person to ask that. I'm not aware of sort of the ensartinib situation, because we haven't participated in those clinical studies, and as you know, it's not approved in the US yet. So can you tell us about switching a TKI before mutation happens while you become NED or almost NED, before your tumor is resistant to the TKI, and revisit the TKI later? Revisiting the TKIs like alectinib, lorlatinib, brigatinib, then starting back from alectinib before any progression. I apologize. I may not be understanding the question fully, but potentially this is asking about switching to let's say you're on alectinib and potentially switching to lorlatinib before you have acquired resistance. So in general, we don't do that. if you've been on alectinib, for example, and you're doing well and it's working well, then generally we have our patients stay on that TKI, because it complicates the situation in that if you switch to, for instance, lorlatinib, and then you have side effects, and then, then we then have to potentially put you back on alectinib, that sort of thing. It's just not something that we generally do. I think the point that this question is trying to potentially address, which is maybe that we need to be aggressive about addressing acquired resistance mutations before it happens. I think that's a critical point, and that's why there's a lot of debate about whether or not lorlatinib should be actually should be the preferred choice in the front line, actually. So, so the thought is that we should be using our most potent and strongest drug up front. With 2 malignancies, can still get into a trial? That's a really great question. Often, clinical studies don't allow patients that have an active, ongoing, concurrent cancer. But that's not true across the board. So it really is very specific to each trial. So I would encourage, further discussion with the clinical trial team just to make sure. But yes, that is a complicating factor for a lot of, for some of our patients. How can we help accelerate your research? Can you accept blood, fluid, biopsies if there's extra material? Oh, thank you so much. That's just a wonderful question, and really speaks to the amazing community, of ALK positive and ALK patients all around the world, and is a big reason why I just really enjoy focusing on ALK. It's difficult in terms of regulatory issues and things like that to obtain biospecimens for our research remotely currently within our protocols, but I know our colleagues in Boston have been working on, or may have already activated, a research protocol. I think it's called Enigma, where you could do a remote consent online and then, send, or at least consent for any extra tissue or blood to be sent for their biorepository. So, I would definitely encourage participation in that. But yes, the biospecimens are really the lifeline of what we do, because that is what allows us to, figure out which questions to ask and to help answer those questions. International collaboration on research. We are 100% open to any collaboration, US or otherwise. So please don't hesitate to reach out. It definitely takes a village. And, I had mentioned in another breakout session that, once we have the 4th generation TKIs up and going, like Nuvalent and TPX 131, we have sort of gotten past the point in the sort of overall research of the sort of the low hanging fruit, so to speak, in terms of, making a better TKI. Now, a lot of the questions that remain are really hard questions. And, for example, STAT3 inhibitors, or, how to eradicate drug tolerant persister cells, how to, develop novel immunotherapies like vaccines and cell therapies and such. So all of that takes, tremendous effort and collaboration. Hopkins does so many clinical trials. Is it easier to get into a trial there if you're a patient at Hopkins, or you can get in as if you're a patient elsewhere? There's no requirement for any of our trials at Hopkins, or I think at any, academic center, that you have to be a patient, beforehand. we get patients referred to us all the time that see us specifically for the purpose of enrolling on a trial, and they were not previously seen at Hopkins. So definitely should be no problem there. Do you think the vaccina trial would be applicable to ALK patients? I apologize. I don't know offhand what the vaccina trial is, Doug. If you could reply back in the chat about specifically what that vaccine entails, I would be happy to chime in on that, because there are multiple vaccine studies around the world, actually. And so I'm not familiar with that particular one. One point to make, though, is that overwhelmingly, the vaccine and cellular therapy studies that are available now or that are, available in the near future really are geared towards patients who have active progressive metastatic disease. For example, patients who are progressing on lorlatinib, for example, or on chemotherapy, that sort of situation. As in contrast, the vaccine that we are working on, which I consider really to be a complementary effort to, for instance, the vaccine that Dr. Chiarli and Dr. Awad are working on. In contrast, our vaccine is geared towards patients who are doing well on, for example, their first line TKI, and who are perhaps have no evidence of disease even. So that's sort of a difference in terms of vaccine approach. Ours is more of a preventative vaccine to try to prevent acquired resistance and allow patients to stay on their alectinib, for example, for longer. Is there a time frame within which lorlatinib is generally expected to achieve maximum response? Oh, interesting question. I don't know. I don't know offhand exactly if there is a sort of a well-described or a published time frame. But in my experience, really within the first 2 scans or so, so maybe 6 to 8 months, that's when we see maximum response, not just with lorlatinib, but with other TKIs as well. Yeah, and to that end, that's actually when, in my personal practice, not standard of care by any stretch, that's when I try, if possible, to obtain a PET scan to see, basically to get an inventory of what else is left that may be active, and then have a discussion about possible local consolidative strategies. Again, not standard of care, but it's something that I try to do for our newly diagnosed ALK patients. I have MS as well. I've always assumed that the etiology to that and cancer were the same. How do your patients with autoimmune problems do, and do you treat them differently than other? Well, I don't know if there's really sort of a tie-in with MS and ALK per se, but the broad sort of observation or correlation is that with an autoimmune disease, if you're on an immune suppressant to control that autoimmune disease, then that can potentially increase your risk for cancer, because by sort of dampening your immune response so that you don't have the autoimmune sort of side effects and flares, you do also dampen your cancer fighting sort of ability of your immune system. So, but that being said, we have plenty of patients who have, for instance, autoimmune diseases like rheumatoid arthritis or MS that don't have cancer. So, so it's just one potential factor. But in terms of interaction with your TKI or that sort of thing, I don't know that VMS is really a significant factor. Now, if we actually had immunotherapy like Opdivo or Keytruda, in our sort of standard tool chest for ALK, which we don't because they don't work very well, then the MS would be a very important factor because, as you may know, getting on, for instance, an immunotherapy while you have an autoimmune disease may make the autoimmune disease worse. Middle chest lymph nodes radiation, any problem with that if TKI is still good? So I'm interpreting that to mean that you're doing fine potentially on a TKI, but that you're asking about consolidation with radiation, perhaps. And again, as I mentioned earlier, that is not a standard practice yet because we don't have the prospective sort of gold standard clinical data to show that by further treating patients who are doing well on their TKI with radiation and or surgery, for example, helps in the long run in terms of helping them live longer or staying on their TKI longer. But we do have some examples from non-ALK cancers to suggest that that may be helpful. So, so that's why I do that, or at least consider that and have a discussion with my patients, when it's feasible. So I would say yes, it would be worth a discussion to consider radiation if that was indeed the question. Should we use TKI combined with chemo to proactively kill residual cancer cells, particularly when having great response to TKI? Yeah, that's a wonderful question. And in fact, I think Dr. Kamich had mentioned this yesterday in his discussion. We have data from EGFR. Again, not with the sort of the most current generation of EGFR TKI, but we do have data from 2 studies actually showing that patients actually live longer if they combine chemo plus TKI up front. Again, we don't have that data in ALK, and so we're in the process of potentially developing such a trial. And in particular using liquid biopsies to try to identify patients who may at least give us a hint about patients who may be at higher risk for progression with just TKI alone, and then having those patients add chemotherapy. So stay tuned. We're working on that concept. Under what circumstances, if ever, would you consider increasing the alectinib beyond the recommended dose after new progression versus simply switching TKIs? The only circumstance that I've really ever done that, increasing alectinib past 600 twice a day is for patients who have had progression just in the brain. Meaning, the cancer everywhere else in the body remains under good control. So increasing alectinib to 900 milligrams twice a day has worked for some of my patients and has been, actually quite well tolerated. So that's the only situation that I've done that. So again, for brain only disease progression. But now with lorlatinib, being out for some time and with data from the first line Crown study giving us sort of some confidence that the side effects of lorlatinib can be fairly well managed, I'm less inclined to do that. To increase alectinib for brain metastases, since we know that lorlatinib works extraordinarily well in the brain. So I would have a conversation about potentially switching to lorlatinib instead. How is progression and change of TKI determined if the patient is having a hard time breathing? How's progression and change of TKI determined? Yeah, I may need clarification of, with that question. I'm not sure if it's asking about, um, the potential that the TKI is causing the difficulty breathing versus, cancer progression. So I would say just in general, it's a good point that, if there's shortness of breath, new difficulty breathing, new cough, it should be in the differential, or the list of considerations, that it's not simply because the cancer is progressing. It may be that, the TKI is causing some sort of inflammatory side effect. That's not fortunately, that inflammatory side effect, called pneumonitis, is not that common with alectinib or brigatinib, but it's definitely something to consider. If a patient has pleural disease, deposits, and mediastinal lymph node disease only, would you recommend monitoring with PET or CT scans? So generally, I would say with a good, high quality CT scan with IV contrast, that would be ideal, because that will allow us very high resolution for those lymph nodes in particular, and allow us to actually measure them fairly accurately, and to track that over time. PET scans, as you may know, often, so a PET scan is basically a PET CT most often. So it's a PET scan overlaid on top of a normal CT scan. The CT part of it for PET CTs often don't have IV contrast. Sometimes they do at some centers, they do it routinely with IV contrast, but often they don't. So that's why for PET scans, you do lose some resolution there, particularly for tracking size, of some of the tumor deposits or lymph nodes, without IV contrast. How do you recommend lowering the level of bilirubin as a side effect of alectinib? Yeah, we do have patients who actually have elevated levels of bilirubin, but it's not impacting them in any significant way. They're not having jaundice, they're not having, other side effects like itchiness, things like that. And most importantly, it's, their liver enzymes otherwise are okay. So we just watch that. And these are just modest elevations of bilirubin, not high elevations. But if it becomes, if it's more elevated, or it starts causing, other issues like affecting other liver enzymes and that sort of thing, then really the solution there is to reduce the dose of alectinib, or eventually switch to a different TKI. 3 non-targetable KRAS mutations have gotten through the pathway at progression for lorlatinib. When lorlatinib and Alimta no longer works, what's next? Yeah, I mean, that's really sort of the $1 million question in terms of, what we're focused on right now in terms of the active areas of research, really just to try to figure out what the best treatment options are for patients who are progressing, despite being on, lorlatinib and then chemotherapy. So, and it's a pretty big topic, but I guess I would summarize and say that, on the near horizon, in fact, already in clinical trials now, are 4th generation TKIs, TPX-131, and also Nuvalent 655. So those are sort of better TKIs, and specifically designed to address compound mutations that can arise from progression on lorlatinib. Now, if you don't have these compound mutations, which occurs in maybe about 25% of patients who have progressed on lorlatinib, it's not clear at all that, going on to like a 4th generation TKI like this would be helpful. And so this is where, some of the newer stuff like combination with MEK or SHP2 inhibitors, or, STAT3 that we talked about earlier this morning, or, novel immunotherapies like T cell therapy or TILs, or the vaccine efforts. That's where we would be looking to. And then just very briefly, yesterday, our colleagues from the University of Michigan, I think, talked about their efforts in their program, in which they have an organoid platform in which they can test your cancer that may be progressing on lorlatinib against various drugs. So and so that's definitely one thing to consider if feasible, for you to enroll in a study like that. We do have a pilot study that's very similar, which we've partnered up with a company that does organoids, and so so we do offer that as well, and the tumors are tested against 40 or so ALK sort of, a drug panel that's very specific to ALK, in terms of potential off-the-shelf drugs that may be useful for this situation, in which the tumor has progressed on lorlatinib and chemotherapy. A lot of things that have been going on lately, the doctors have blamed COVID for. He had COVID a month ago, specifically his immature granulocytes have been elevated for the past month. Platelet count went up. How could this be COVID? Yeah, so I think this is sort of one of those types of specific questions that would probably be best discussed more sort of in a formal setting, because there's a lot of details about that specific case that I think it would just it would be super critical to know some of the other details about that case. So I apologize. I will probably, I'll defer on that question, because it's really important to know some of the other details of that case. How proactive should we be pursuing eliminating residual disease if we're stable on current treatment? Yeah, and that's a good point. And, and that's been an active topic this morning and in the other breakout sessions. If you were able to hear Dr. Carbone, that was one of his closing messages, and I'm fully sort of aligned with that, which is why, I've been involved in sort of the local consolidative, radiation approaches with the Bright Star trial at MD Anderson. And then, which is why I use local consolidative therapy, with my patients as much as is feasible, which is why we're working on a vaccine specifically in this setting where patients are doing well, and to try to be proactive before things progress and are thus harder to sort of rein in. So I guess my recommendation there would be to seek out opinions, to see if doing more would be helpful. And again, to be clear, surgery and or radiation for consolidation is not the right answer for a lot of patients. So, but it can be for some patients. So, I guess I would just encourage just, maybe, seeing one of the ALK specialists that are associated with a group, or, just asking around.
I think that's it.
All right. Looks like we're out of time. I'm so sorry that we didn't get to the other questions. Thank you so much for joining.